Well, good afternoon, everybody. Welcome back to the Congress Center. My name is Günther Fink. I'm an associate professor of epidemiology and economics here at the University of Basel and also head of a research unit at the Swiss Tropical and Public Health Institute. As some of you may know, I was also part of the local organizing committee, and it has been amazing to work with the team and really great to see all of these sessions come together, and I hope you enjoyed the program so far as much as I did. I am, of course, also truly delighted to have the honor to introduce our keynote speaker tonight, and I'm very confident that once again she will take this conference to new heights, as the title of the conference suggests. I think many of you already know Dr. Currie, so I will just say a few words to summarize her amazing achievements over the past decades. Dr. Jenny Currie is Henry Putnam Professor of Economics and Public Affairs at Princeton University and also Director of Princeton Center for Health and Well-Being. She's a member of many associations, maybe most importantly the National Academy of Medicine and the American Academy of Arts and Sciences. She's also a fellow of the American Academy of Political and Social Science and of the Econometric Society. Dr. Currie got her BA and her MA in economics from the University of Toronto and her PhD from Princeton. Since the 1990s, she has really pioneered research in the areas of early childhood health, early childhood development, and their human capital implications. One of the key areas, of course, has been the area of early inequalities and thinking about how we can best improve outcomes in the short and long run. Dr. Currie has published well more than 100 publications, mostly in the very top economic journals, where she has built a field that is really trying to understand the early roots of inequalities and how to best build human capital in the long run. She has assessed many different programs. She has worked on things as diverse as health insurance, public housing, food programs, nutrition programs, any kind of public policy that relates to health and economic outcomes in the short and long run. She has also worked extensively on socioeconomic differences and about the best ways to improve things, once again, in the short and long run, has worked on the major threats of health, environment, and also on issues of mental health. She has written many papers that have cool titles like Healthy, Wealthy, and Wise, or they start with those, Killing Me Softly, and with such research contributed to a field that now has really changed or started to change policy and has made many people in the US and internationally think about the best ways to improve early childhood health, early childhood development, and giving everybody a fair chance. As you will see in a few minutes, this field the field of early childhood health, the field of early childhood development has really grown substantially in the last few years. I think he will show the graph that really shows the massive increase in publications. And I think this is really a result of many people being inspired by your work and the work of the field, including myself. And I think it's very exciting to have you here today and to think together about the best ways to decrease early life inequalities and to think about the best ways to give everybody a fair chance in life. And as we've seen in our first keynote on Sunday, there are still quite a few gaps in the US to be filled, and the same holds for pretty much every country in the world, including Switzerland, where we are today. In recognition of her amazing contributions to the field of early childhood development, Dr. Currie was awarded an honorary doctoral degree by the University of Zurich in 2017, and it is our great pleasure to have her back here with us in Switzerland tonight. So please give a warm welcome to Dr. Currie. Thank you.
So, thank you very much for that warm introduction and for inviting me to come and talk to you today about child health and human capital. Let's see if I can get this to go. There we go. So, as Günther was saying, child health is increasingly understood to be a very important form of human capital, which makes it a proper subject of study for health economists. In this lecture, what I'm going to try and do is review some of the highlights from the recent literature. I'm going to explore an extended example of an intervention to extend child health insurance and look at its effects. I picked that intervention in particular since this is a conference of health economists. And then I'm going to suggest some directions for future research, focusing in particular on mental health and also on the missing middle years. So, as Günther said, There has been a big increase in research. This graph is showing the number of papers in top economics journals and top field journals that have the term fetal origins or fetal health. This is my one nod to the theme of new heights. You can see the new height there at the end. But when I started working on this in the early 90s, I remember talking to a very senior and respected economist who will remain nameless, who asked me what I was doing, so I told him in some detail, and he listened, and then he said, oh, well, that's nice, but that's not economics. So I just throw that out for all the junior people here that, economics is a big tent. You can study a lot of different things, and you can see people have come to agree with me that studying fetal origins is an important thing to look at. So the importance of fetal origins, I think, is now pretty well established, and we found that the magnitudes are large and the period in utero is small, which suggests that concentrated investments in pregnant women could have a long-term payoff. One of the overall takeaways from this literature is that both nature and nurture matter. So we shouldn't be talking anymore, is it nature or is it nurture? It's always both. And the interactions are very important. And increasingly, economists have moved beyond the fetal period and pregnant women to think about early childhood. To think about both the fetal period and early childhood, it's helpful to have a conceptual framework. And so that's what I've tried to write down here. The top equation is a production function for child health, where there are two periods. So if you like, you could think about the first period as the fetal period and then the second period as childhood. The bar over the investment in period 1 indicates that those investments have already been made, so now we're thinking about investments in period 2. Big A is a shifter of the production function. Gamma just shows the weights on investments in the fetal period versus investments in later childhood. The mu's are shocks, which you could think of as some kind of group level shock, either in utero or in early childhood. And the phi is measures the substitutability of investments between one period and the other period. So parents have this production function, and then they maximize their utility, which depends both on their own consumption and on the health of their child, subject to a budget constraint. So one of the things you could do with this framework is think about how substitutable investments are between different periods. If phi is equal to 1, then you can derive the expression that's given there as a function of the alphas and the gammas, or if investments were at the other extreme perfectly complementary, you would get a different expression. So one thing you could conceivably do with this framework is to try and estimate all of these parameters and then say, are investments substitutes or complements? I'm going to focus on a different aspect of this model, though, which is that there's lots of parameters, even in this really simple model. So families can differ in terms of this shifter of the production function, in terms of the weight that goes on period 1 versus period 2, in terms of the weight in their utility function on child health versus their own consumption, and also in terms of prices. And social programs can affect these parameters in different ways as well. Also, depending on where you start, the exact same investment could have different effects. So we all think of production functions as being concave. If you're on the really steep part of the curve, an investment is going to have a big effect. If you're on the flat part of the curve, it's not going to have such a big effect. So one of the things I take away from this model is that you should expect and look for a lot of heterogeneity in the effects of different shocks. So if you were taking this model to the data, these heterogeneous effects could be due to differences in preferences, differences in constraints, or differences in production functions. And it can be very difficult to distinguish between those things. It's going to be really hard at this point to estimate any of those underlying constructs without making some really strong assumptions on the data. So this is where I think empirical evidence really helps. If, for example, you're willing to make some assumptions that, for example, parental preferences don't change really fast when there's a policy change, or that underlying production functions don't change really fast when there's a policy change, then if you see a big effect of a policy change, it might be reasonable to interpret that as the effect of removing constraints on parents subject to fixed preferences and fixed production possibilities. So I'm going to talk about, as I mentioned, an extended example of an intervention that's going to show a lot of heterogeneous effects, which I'll emphasize. And the example is the extension of public health insurance to pregnant women and children in the United States. The program is called Medicaid, and this program was greatly expanded in the US beginning in the late 1980s and extending through the 1990s. These expansions had much bigger impacts, as I'll show you, on poor and minority children. And because there was so much variation in how they were implemented, they give us a fairly unique opportunity to study the importance of providing public health insurance for children. So the phase-in of public health insurance for pregnant women occurred at very different rates in different states. And this figure is trying to show that. The dark parts show states where there's a really big change in eligibility. The light parts show places where there was a smaller increase in eligibility. This occurred for two reasons. One was because some states were really stingy to begin with, like a place like Mississippi, which is the darkest one there. Or is that Louisiana? My US geography is still shaky after all these years. Anyway, that state was very stingy and was forced to extend eligibility. A state like California, on the other hand, was generous, but became even more generous over time. So using another way to summarize what was going on is just to look at the fraction of pregnant women who are eligible for public health insurance coverage of their pregnancy and delivery, which went from about 12% in the 1980s up to 43% by the early 90s. And even today, about 45% of all births in the United States are paid for by the Medicaid program. So I did some early work on these eligibility expansions showing just the short-term effects, which were fairly dramatic. With John Gruber, we estimated that there was an 8.5% reduction in infant mortality, and we were able to link that reduction in infant mortality to greater use of medical services. So, for example, there was a very large reduction in delay in obtaining prenatal care among mothers who are in the highest poverty groups. One of the things that I'm really excited about current research is that there's now new evidence about the long-term effects of this prenatal coverage and infant coverage on these children. So children who were covered in 1990 are now young adults, and we can follow these cohorts up to the present time and see, well, what's the effect on these cohorts who were covered compared to cohorts born just before who were not covered. And in a very nice paper by Sarah Miller and Laura Weary, they show that these young adult children of mothers who are eligible are less likely to have chronic conditions, have fewer hospital visits, and are more likely to graduate from high school. This is the overall effect. And then if you focus on the poorest, you see much larger effects. So you see 2/3 of a standard deviation reductions in the probability of having a chronic condition, almost a whole less hospital visit, an even bigger effect on graduating from high school, and then a whole range of effects that don't show up significantly in the full sample, but show up in the subset of more disadvantaged mothers, such as increases in the probability of college, increases in personal income, decreases in the probability of using food assistance, and I think very intriguingly, a decline of 2 points on the Kessler-6 mental distress score. So this thing is scored from 6 to 30. A score of over 13 indicates that the person is in mental distress. So a reduction of 2 is actually quite big on this scale. Among children, you can also use the variation in eligibility to identify the effects. In this case, there's a quirk of the law such that only children who were born after September 1, 1983 were ever eligible for these expansions. So you can compare those children who are eligible to cohorts born just before who were never eligible and see what the effects are. And there's a lot of people at this point who've looked at this, looking at different data sets and different outcomes, some listed here. Just to show you this variation, on your left is a figure that shows the number of years of Medicaid eligibility for children who were born in 1981. And then on the right, there's the number of years of Medicaid eligibility for children born in 1984. And you can see the right-hand side figure is a lot darker, indicating many more years of health insurance eligibility. You can also look at this by age. Here, the youngest groups got health insurance first. That's the top line in dark blue. And you can see that the number of children who were eligible went up from 20% to over 50%. The oldest children, coverage kind of lagged, but eventually a lot more of the older kids were made eligible as well, so that their rates went up from about 15% to over 40%. Okay, so you can see many children are eligible for these programs now in the United States. Using this kind of discontinuity design that I was talking about, this is just one example. This is from a paper by Laura Wary and co-authors. So you can see the line at September 1983. These are people who were born in the 50 months before. These are people who were born in the 50 months after. There is a secular trend towards lower hospitalization rates, which you see in every age group. But you also see this sharp drop in hospitalizations between the cohorts born before and the cohorts born after. This is for African American children, 21 to 28 years old. And in their paper, they don't find an effect on hospitalizations among white children. So again, you see this very heterogeneous effect. In the United States, we heard quite a bit in Raj Chetty's talk that African Americans were much more disadvantaged than whites, so they're more likely to be eligible for these programs, and then you see larger effects on them. You can also see the effect of this expansion of insurance on the famous income health gradient. So here on the left is essentially the gradient that Case Lobotsky and Paxson talked about in their paper. You have on the bottom x-axis the log of family income, on the y-axis an index of health, where a bigger number indicates poorer health. So all these numbers slope down, which means that poorer children are in worse health. Now, what they wanted you to pay attention to, though, was that not only are poorer children in worse health, we knew that already, but the lines rotate as the children get older, so that the effect of income seems to be greater as the child gets older. Okay. On the right-hand side here, the graph is drawn for the years 1986 to 1990. So this is pre-Medicaid expansions. If you look in the years 2001 to 2005, you see that these lines have started to come apart. They've gotten a lot flatter. And the reason they're coming apart is because the expansions came in faster and were bigger for the youngest children. Okay, so you see a big decline in the number of young children in ill health. You still see the rotation out, but even for the oldest children, there's a flattening of the gradient. So you're not eliminating it, but you are attenuating it somewhat. Okay. Another way to look at the effect of health insurance in the United States is to compare it to another place. And I would argue that Canada is a good comparison because Canada is very similar in terms of things like wealth, the kind of medical technologies that are available, even things like the amount that people drive, which affects mortality due to traffic accidents. But a really important difference is that Canada's had universal public health insurance since the 1970s, whereas the US had this large expansion for pregnant women and children that we've been talking about. But prior to that, there really hadn't been much change in the availability of public health insurance for adults, and it was really very limited prior to the Affordable Care Act. And so what I've done in some work with Michael Baker and Hannah Schwant to implement this kind of mortality comparison is to first take counties as a sort of common geographical area, rank counties from the richest to the poorest, sort of put the counties into bins, each accounting for about 5% of the population, and then for each census year, compare the top 5% and the bottom 5%. And that way, each bin always has about 5% of the population in it, which is why we're grouping like this. Okay, so just to kind of summarize what goes on when we do this, if you look at these figures, let's focus here on age 0 to 4, so these are young children. Along the x-axis, we have the poverty percentile. So here 0 are the richest counties, and 100 is the poorest counties. And along the y-axis, we have a mortality rate. Okay, so here the lines are upward sloping, and that's because mortality is higher in the poorer places. Okay? So if you look at the two blue lines, which are the lines for the US, the fainter one is for 1990, the darker one is for 2010, and what you see is a very large decline in mortality in the poor places compared to the rich places in the US. Okay? The red lines here are for Canada. If we do the same comparison, 1990 to 2010, we see that there's a decline in mortality, right? So there's always progress being made, and you could think of that as due to better technology or better car seats, better cars, things like that. The gains in Canada are pretty evenly distributed. But what I really want to draw your attention to is that by 2010, the US line and the Canadian line are really close together. Okay? So the death rates for US children converged to the much lower rate for Canadian children. Okay? In contrast, you don't see that for any other group. And we've done this for all of the groups, and I'm just picking out two here. If we look at 40 to 44-year-olds, I should say this is for women, it's quite shocking that you see hardly any gain in terms of mortality over the whole period from 1990 to 2010. And this is something that Case and Deaton have written about. Okay. You do see some decline in mortality in Canada, okay? But by 2010, there remains a huge gap in mortality rates in poor places between Canada and the US in this age group. Okay? It's the same thing if I look at the 60 to 64-year-olds. There's also a huge gap in mortality in the poorest places, a smaller gap in the richer places, but still a gap. Okay, so that's for women. If I look at men, you get a very similar story. Again, the lines have almost converged for children, where we had these big gains in health insurance in the US. And then we still see some fairly large gaps for other age groups. Okay. This kind of evidence about the effectiveness in the long term of health insurance has also been replicated recently in the UK. So Wilson and Lehrman have a nice paper looking at the rollout of the National Health Service, which came to different geographic areas at different times. They showed that there was an immediate drop in infant mortality when the National Health Service reached an area, which is the same thing that I found with John Gruber. And they can follow people longer since NHS started in 1948. So they look 50 years later and see a 14% reduction in mortality at age 58 among the affected cohorts. Okay, so what I've showed you so far is evidence that children with access to health care from the prenatal period and from early childhood live longer and they're healthier. But, being economists, we might ask, well, do they earn more? And, traditionally, economists, when they talk about human capital, are talking about something that causes people to earn more money. It's possible that interventions that save a lot of unhealthy babies could lead to a sickly pool of survivors, and maybe people would have lower average wages. People often ask me about that. So fortunately, the availability of administrative data allows us to assess the effects of these things that happened long ago by looking at cohorts who are affected. And in some work with Doug Almond and Valentina Duque, we review several interventions in the prenatal and early life period that seem to have long-term effects on wages. One of them is what we've been talking about, the expansion of health insurance. This figure is from a paper by Brown, Kowalski, and Lurie, where they're looking at the tax data, which is the same data that Raj Chetty uses, and looking at the effects of having gained an additional year of health insurance on taxes paid between the ages of 19 and 28. Okay? So along here is total taxes paid. And they're looking at 3 different groups of children, people who are in families with incomes less than 200% of the federal poverty line. So these are the poorer families, a sort of medium group of families, and then a richer group of families. And what you can see is that in the poorest group, there's an increase of about $1,800 by age 28 in the annual taxes paid. So that's indicative of higher earnings. You also see an effect in the middle group, and it even looks like there's some effect on the richer group, which was the least likely to be eligible for public health insurance. So, you could interpret this one of 2 ways. One way is that you want to look at this gap and say, well, that's the effect on the poorest families. Another way is to think that, well, there could well be general equilibrium effects of making it the case that every child who walks through the door has health insurance on the type of care that's offered. And in some other work that I've done, I've shown, for example, that hospitals were more likely to adopt NICUs, were more likely to have maternity units at all after these changes went into effect, because it meant that every pregnant woman who walked in the door was going to be a paying customer. Okay. So the Brown et al. Paper is this bar here. And what I've done in this figure is to take all of the papers that we were aware of as of the writing of this paper. And this literature is moving so fast, I'm sure that I've left out some really good papers here. And just plot the increase in wages that was associated with the intervention. So these are increases in wages in adulthood associated with interventions in either the fetal period or the childhood period or both periods. Okay, so what this is showing is a positive effect of the increase in health insurance, a positive effect of an intervention to reduce alcohol exposure in utero, a positive effect of a childcare subsidy program, a positive effect of a paid maternity leave program, a positive effect of reducing maternal flu exposure, and a positive effect of reducing air pollution. So, this isn't exactly an apples-to-apples comparison, as I haven't talked anything about the cost of these interventions, but I think it does show that there are possibilities for improving people's human capital through a variety of means. This figure is for rich countries. You can do the same thing for poor countries and see effects that are actually kind of in the same ballpark. Here, the first two interventions are thinking about reductions in the overall prevalence of disease. The third one is looking at a deworming intervention. The fourth one is looking at a program that involved home visiting with psychosocial stimulation of children and a nutritional component. And the fourth one is looking at an intervention to address micronutrient deficiencies, in this case iodine. So again, you can see a range of positive effects on future wages that are associated with these interventions. So I would summarize that evidence as saying there is still a lot of low-hanging fruit around in terms of improving child human capital by addressing disease in various ways. In rich countries, you would do that by improving access to health insurance, by making sure that all kids are immunized, both for childhood diseases and for influenza, and adults also need to be immunized for influenza, and by reducing substance abuse, which we know is a serious problem. In developing countries, we're still working on reducing the overall burden of infectious disease. Parasites can be an important problem, and it's important to look at micronutrient deficiencies. However, there's also a hint from these tables about other types of interventions that might act through what economists have been calling non-cognitive skills, although the rest of the world calls it either psychosocial functioning or mental health. So I'm just going to call it mental health. And say mental health is one of the most important determinants of adult outcomes. I'll show you some evidence of that. It's particularly interesting for someone who studies child health because a lot of mental disorders, even though they manifest in adulthood, they seem to start in childhood or even in the fetal period. And mental health problems are extremely common. Okay, so just on that latter point about them being very common, this is some data from the US General Social Survey where respondents have been asked since 2002 the question that's in the middle of the plot there. Now, thinking about your mental health, which includes stress, depression, and problems with emotions, for how many days during the past 30 was your mental health not good? Okay, and I think it's quite surprising that if you look, for example, at this purple line, that over 10% of the respondents say that out of the last 30 days, more than 10 days were days when their mental health was not good. Okay, so there are an awful lot of people who are feeling, stressed, depressed, and so on at any point in time. You can also see this when you look at medical costs. So in the United States, people who are having a mental health crisis are advised to go to the nearest emergency room. So one way that you can measure the impact of mental health problems is by looking at ER visits. And if you do that, this is for 6 states, looking at all ER visits, you see there's about 380 visits per 1,000 overall. And of those, 13.4% have a mental health indication. Right? They may have other indications as well, but they specifically say that the person is suffering some kind of mental health problem. 2.8% it would be substance abuse without any other sort of mental health problem, but 5% are mood disorder like depression or bipolar. Another almost 5% are people suffering from anxiety. Okay? So this is very costly and is affecting very large numbers of people who are showing up in the emergency room. As I mentioned, mental health problems often begin in childhood and then continue into adulthood. In some work using Canadian administrative data, we tried to look at the burden of mental health compared to the burden of common physical health problems for children. And so we compared the most common mental health problems, which were ADHD and conduct disorders, to the most common physical health problems, which were asthma and injuries, and looked at 4 different age ranges, as well as persistent conditions. So we had 50,000 Canadian children and their siblings. We were able to merge the health records to education records and welfare records. And the outcomes that we looked at were whether they were on welfare after they were 18, whether they were on track in school, which we measured as saying, were they in grade 12 by age 17, and were they taking the math courses that they needed to take in order to get into college. So in Canada, you have to take some set of courses or you're not eligible to go to college. Okay. And what I've done here is just to plot out the coefficients from sibling fixed effects models. And I think what this shows is how much greater the effect of ADHD and conduct disorder are on these outcomes, in this case being on welfare after age 18, than the effect of physical health conditions. You see the same thing if you look at whether they're taking the math courses that they need to take to get into college. And if you look at persistent health conditions, that's the orange bar here, those have the largest effect, followed by conditions that were only treated from age 14 to 18. Okay. I also mentioned that prenatal conditions can place children at higher risk of poor mental health. We have, at this point, quite a lot of evidence that that's the case, starting with the studies from the Dutch hunger winter, which linked mothers experiencing famine during pregnancy to a higher incidence of schizophrenia in their offspring. There's been some similar results showing the effect of exposure to war on schizophrenia, and then taking a less drastic condition, ADHD, there is a nice paper using a sample of Danish twins and showing that even if you look at identical twins, the lower birth weight twin is more likely to have ADHD. A recent contribution to this literature by Petra Pearson and Maya Rosen-Slater uses Swedish registry data to look at the effect of the death of a close maternal relative. And they make the point that families that have deaths are not typical families. They're not randomly selected from the population. So you don't want to just compare those families to every other family. You want to compare them to a family that's a good control. And so for that, they pick families who experienced a death in the family after the pregnancy. Okay. Doing that comparison, they find that the probability in the offspring of using an ADHD drug increases by 25% if the mother experienced this stress. And also, if you follow those same cohorts into adulthood, the probability of using drugs for anxiety or depression rises by 13% and 8%, respectively. Okay, so we can harm children in utero. We know that now. A question is, can we help children while they're in utero? Are there interventions that we can do that will make things better? And we saw a hint of that from the Miller and Weary paper, showing that in the cohorts that got health insurance during pregnancy, the offspring had better scores on the Kessler Index of Mental Health. In some recent work with Anna Chorney, I've been looking at a different program, which is called WIC, Women, Infants, and Children Supplemental Nutrition Program. And as the title suggests, this is a nutrition program, but it also helps people to access medical care. What we see in the data is often people who are eligible don't necessarily get the care that they need, and WIC helps them to actually get that care. The children in our sample were born between 2004 and 2009, and then we can follow them up to 2015. And what we see is that if we compare these children to siblings who did not benefit from WIC, the index siblings are less likely to have ADHD and other mental health conditions that are diagnosed early in childhood. Those effects are much bigger, again, for African Americans. There's some hint that they're also bigger for low-income families. In this sample, we don't see an effect on anxiety and depression, which I think is because the kids are 6 to 11 and you don't really see those effects manifesting until a little bit later. Okay, so I'm arguing that, first of all these kids got access to care. Secondly, access to care ought to have improved their mental health. And so I think an obvious question is, well, why do we hear all the time about how mental health is getting worse for kids? Okay, and I think a really important thing and a difficult thing for people trying to do empirical work is that the diagnostic standards for many conditions change over time, and that there are also these big changes in coverage and some changes in the incentives facing providers to do screenings, which result in more cases being identified. So you have more access, that leads to more screening. If you have more screening, then you're going to get more cases and you're going to find more people being treated. Okay. So to show some evidence of that, I'm going to talk a little bit more about Medicaid. In this figure, what I'm showing is prescriptions for ADHD. Those are the solid lines. The dashed line here is all prescriptions for children, which are actually falling over this period. So the top line, the blue line, is showing overall prescriptions for ADHD, which are increasing in the US. The red line is Medicaid, okay, and you can see that tracks really well, the overall. And then the green line is private health insurance. So what this shows is that all of the increase in treatment for ADHD is coming over this period from the Medicaid population. Okay? So what was happening in Medicaid? Well, in Medicaid, what was happening was they were switching from fee-for-service to managed care. And there's two reasons why that might matter. One is that it's easier for the government to hold the managed care company responsible for doing screenings than it is for them to track down individual providers and make sure that individual providers are doing screenings. And the second thing is that managed care plans have a financial incentive to provide screenings because they get a higher capitated reimbursement rate for kids with chronic conditions than for kids without chronic conditions. Okay. So we look at the effect of this switch to managed care in South Carolina, where the state switched the plans between October 2007 and May 2008. And we have a 60% sample of all the children in the state who are on Medicaid at any time. We use two different identification strategies. One is an event study where we look at kids 2 years before and 2 years after the switch. And the other one is that we can actually look at kids who got put into managed care and see whether they then got more likely to be diagnosed with something. So in the event study, you can see that switching to managed care increases the number of well-child screenings, and the number of kids being treated for ADHD tracks right along with that. In the child fixed effects, you also see a big increase in screenings. Okay, so this is exactly the same child, and just saying what happens when that child gets covered by managed care instead of fee-for-service. They're more likely to have a well-child visit. They're more likely to have a developmental screening. They're way more likely to get vaccinated, somewhat surprisingly, since they're all supposed to be vaccinated anyway, and they have more sick visits. Okay? And then if I look at whether they're being treated for condition, we see increases in treatment for ADHD, increases in treatment for depression, but also increases in treatment for asthma, for mild infections, for ear, nose, and throat conditions, which are very common in childhood, and for autoimmune conditions, among other conditions. So you can see that this is increasing the consumption of medical care kind of across the board. I think people tend to feel differently about saying, oh, we identified a bunch of kids who have asthma and now we're treating them. That's good. if you say, well, we identified a bunch of kids and now we're treating them for ADHD, people think, I'm not so sure about that. But this shows that it's good to put it into context of all the medical care that people are getting. Okay, so we've touched a little bit on prevention and on the diagnosis of mental health conditions. And so I think the next frontier is to be able to say something about treatment. There's all these kids getting treated. Is that helping them or not? And just as the US can serve as a laboratory for understanding the effects of health insurance, I think it can also serve as a laboratory for understanding the effectiveness of treatment, given that there are very large variations in practice style across regions. We know there's a huge literature on that, but even within regions, within hospitals, within individual practices, there are huge variations in practice style. And we have increasing availability of administrative data, both on treatments and also on important outcomes, like whether children show up in the emergency room. So this is a picture of antidepressant drug use by county per 1,000 people 10 to 19 years old in 2014. The source of data here is a company that collects data on all retail prescriptions in the United States. So this is a fairly comprehensive picture. The scale here goes from 0 per 1,000 in some counties to over 967. That's the darkest area. Okay? So there are some areas in the United States where every child on a per capita basis is getting a prescription for antidepressants. So this is pretty amazing, I think. There are other things you can see in the data. So for example, it's well known that women are more likely to be treated for depression than men. You see this starting very early among children. You see the same thing, that girls are more likely to be treated than boys. If you look at who is doing the prescribing, a lot of this prescribing is done by general practitioners who don't necessarily have very much training for using these kind of drugs. And again, there's a lot of variation. I think if you're used to looking at maps of the United States where the red part is always in the south, this one is a little bit surprising, where the red part is across the north part of the country, showing that GPs in these areas have high propensity to prescribe antidepressants. One reason for that may be that a lot of these are areas where there are no psychiatrists who treat children. Okay? So there are many differences in access to types of providers, many differences in how providers are behaving, thousands of children being treated. And this is happening even though we don't have very much information about efficacy in this group. Okay, so all of these antidepressants that are being prescribed, without exception, carry black box warnings that they may increase suicidality up to age 24. Very few of them have been tested in children. There are only a few that are approved for treatment in children, which means that almost all of the use is off-label, and nobody's tracking it, except us, maybe. So there's really unclear real-world health implications of all of this antidepressant use among children, which I think is an urgent topic for research. I want to pivot a little bit to one other thing that I think is an urgent topic for research, which is this missing middle years and the discussion of mental health, which really starts affecting kids in a big way, often in their adolescent years, is a good segue to talking about the importance of adolescence more generally. A lot of the research that I've been talking about is about the fetal period or the early childhood period, and a lot less is known about adolescence health and its relationship to adult outcomes, with the exception of the literature on risky behaviors. So we know a lot about teen pregnancy and teen smoking and teen drinking, but we don't know a lot about other aspects of teen health. One reason why this would be useful is that if we knew more about which measures of adolescent health were very predictive of adult health, then it would be a lot easier to gauge the efficacy of some of these early childhood interventions. We wouldn't have to wait until the people were 30 or 40 years old to see what the effect is. We could see the effect on some intermediate outcome, which might be valid for predicting the future. Another point is that we might be able to target interventions more effectively. So right now, our thinking seems to be that, well, we know that early childhood is really important, so we'll do these interventions for all children in the early childhood period. It might possibly be more cost-effective to focus our resources on adolescents who needed help if we could properly identify which interventions worked for that group and which people needed help. Okay, so to summarize, there's been really an explosion of literature demonstrating that child health is an important form of human capital. We have lots of evidence now that healthier children live longer lives, they get more education, they earn higher wages. And yet, I think we're still at the early stages of unraveling what the mechanisms are. The available evidence does show that public policy can help. It can relax constraints on families and promote child health in many different ways. While the improvement of physical health remains important, there's a new understanding of the importance of mental health as well for future outcomes. And we see that mental health diagnoses in children are increasing. This isn't necessarily a cause for alarm. It's due, at least in part, to improvements in screening, diagnosis, and maybe in treatment. So there are some really difficult measurement issues going forward in thinking about what these trends mean. Going forward, also, more attention to adolescents, these missing middle years, is likely to be very important. So that's all I have to say, and I'm really happy to take questions.
Thank you. I'm not sure. Thank you very much for this really great talk. I'm sure there will be questions. Please raise your hands. Yes, please.
Can I speak from here? I'm Sadiqul Islam from Laurentian University of Canada. I thanked Professor Adhd for comparing US-Canada. I'm going to do the same thing here. Question number one, have you compared the US with other countries, let's say the Nordic countries? Probably you'll get the similar results. The second question, also, have you examined the role of two other sets of policy variables, like child support programs and, let's say, early childhood education programs? I'll make a short comment here. In Canada, we have the public health insurance system, but Canada's record in child poverty is still not good. Canada has a somewhat high child poverty rate, but within Canada, there is significant differences. Quebec has better child support programs compared to other provinces, and it matters. So I wonder whether you can make some comments. Yeah. Thank you.
Okay, that's a kind of complicated question. But in terms of comparing the US and other places, one reason why I think the US is interesting, even to Europeans, is because in a lot of European countries, there's just one before and after, right? There was some point where national health was introduced, and then it's been in existence for a long time, so it's a little more difficult to see what the effect might be. But I would argue that, for example, the English paper suggests that health insurance has similar effects in other places. In terms of the other things you were talking about with Canada, I don't want to get too much into the weeds, but one of the things that I learned doing that Canada-US comparison was about the way that Canada calculates poverty rates. And there's a lot of issues. For example, they assume that people need much more money to live in a city than to live in any place else. So a city like Toronto has a really high poverty rate, although they have very good health outcomes. So if you think like that in most places, life expectancy is lower in a poor place, in Canada, if you use the literal poverty measures that StatsCan puts out, which they don't call poverty measures, right? They call low-income thresholds. They don't have a poverty measure, really. Anyway, if you do that, you get the reverse relationship. So I would say there's something wrong with the poverty measures in Canada, though we tried to avoid saying that so baldly in our paper. On the childcare, there has been quite a lot of research on the childcare program in Quebec, some of it not very favorable, right? So they have this $7 a day childcare program in Quebec, which was rolled out. Some evaluations have found negative effects of that program. I think what you need to think about in all of these evaluations is, well, what is the counterfactual? So in Quebec, the effect of the rollout was to have a lot of children end up in not very good childcare because they really scrambled to find places. And so if you take kids who were, at home with their mom and encourage them to go into bad childcare, that may have a negative effect on children, right? On the other hand, if you have children who are, alone watching the TV and they get put in good childcare, that will probably have good effects, right? So you have to consider carefully what is the counterfactual and also, heterogeneity in the effects.
David?
Thank you, David Bishai from Johns Hopkins. Excellent talk. Thank you so much. Tomorrow's plenary, we'll be talking about success stories where economic evidence made a difference. Now, the glass is half empty in the U.S. because the Affordable Care Act allowed many states to expand Medicaid and they didn't take the opportunity. But I want you to know, to your knowledge, is the glass half full? Were there marginal states, not the obvious ones, where this was the sort of evidence that swung the vote in those states that really needed a push to get a Medicaid expansion across the finish line?
So I know for a fact that my work with John Gruber showing the reduction in infant mortality was widely discussed in the run-up to the Affordable Care Act. One reason for that, it was an unusual administration. The Obama administration hired a whole bunch of academics who all knew the academic research, and so I think the academic research had more of a bearing on public policy than it often does. But I know that it had an impact, and I take some hope from that because that's something that I was doing, in the mid-90s, and you do it, and it gets published, and that's great. Some people cite it, and it doesn't seem to have any impact on policy. And then, 30 years later, there's a sleeper effect, and lo and behold, people are talking about it again. We had at the American Health Economics Association meeting a panel of journalists who said, there's two ways to get your work out there. And one is to react to the news as it's happening. So, if you're doing a study on something, like say you're doing a study on opioids, and then all of a sudden everybody becomes really interested in opioids, then people will want to talk to you. But another way is to sort of follow the news and realize that, well, if they're doing a policy on health insurance, now all the old literature on health insurance is suddenly relevant again. And so now is the time to bring it to the attention of policymakers and journalists who might be in a position to get it out there.
Over there.
Hi, Dana Forgione from University of Texas at San Antonio. I was very concerned about the statistics you showed about the use of antidepressants among almost, in some years, nearly 100% of the children. And you cited the financial incentives, the higher capitation rates for treating children with chronic conditions, also that we have incentives for leaning more towards drug therapy versus talk therapy. And we know that the drugs don't make the problems go away, they merely suppress the chemical processes, and the problems could in fact be getting worse while the child is under that antidepressant medication. So it seems to me that with the high correlation you cited with teen suicide, or suicidality, that we got a serious perverse financial incentive problem here. That we've got GPs throwing drugs at kids that maybe they don't really need or aren't appropriate, and could in fact be correlated with high teen suicide. And we once again, instead of incentivizing appropriate care, we could in fact be incentivizing the wrong kind of care.
Yeah, I totally agree. And so that's one reason why I'm highlighting these kind of numbers. I think we can't say, just because a lot of people are being treated, that that's a bad thing at this point, but it's at least a kind of suspicious thing that deserves more looking into.
I think gentleman in the back.
Hi.
It's on, it's good.
I just wanted to follow up on that point.
Can you speak up a little bit?
Sure. So the counties that were showing 100% or 95% of kids on antidepressants, I think that may not be a correct interpretation. It may be some of those kids were on 2 antidepressants. So the statistic was a ratio of prescriptions per capita. So it could be that half the kids were on 2 antidepressants, which is not great either, but it's not the same as 100% on 1.
Yeah, also I should have clarified that a lot of these scripts would be for 1 month. The majority of scripts would be for a 30-day supply. So you might want to take that number and divide by 12 when you're thinking about per capita. And then, as you say, some children, quite a few children actually, are on more than one drug, although if you think about it, like we don't have very good trials for one drug per child, and we don't have hardly any trials looking at interactions between different drugs, and yet lots of children are taking more than one drug.
Yes, please.
Janet, thank you so much for a really inspiring and interesting talk. I'm Zomei Chang from Princeton University, USA. You've talked about the effect of health insurance on early childhood health and development. And it's been a nagging question for me as to whether by the time you cover pregnant women, to give them prenatal care, it's already too late. By then the damage, so to speak, is done, because we know the impact of epigenetics, that the eggs that a young woman carries is affected by the year of growing up. And so that if you only begin to carry it, to cover the mother-to-be when she's pregnant, the effect of the intervention may be limited. So I just wonder whether you have any plans to go into the pre-pregnant state of young women and compare, say, if you cover, suppose we had universal health coverage, whether the outcomes will be better overall from a population point of view.
Right. So there's actually several people working on that that I know of. Because if you think about it, so these cohorts of women that were covered, that their mothers were covered when they were in utero, now those women are in their, between 20 and 30. So they've been covered since they were in utero on public health insurance up to age 18, and now they're having children of their own, right? So we can start to see what the impact is of the child having health insurance through their whole life on the health of their children. Yeah. So I don't have the results, but I know that people are working on that.
There's a gentleman in the back over there.
Hello. This is Ismael Ortega Sanchez from CDC US. I think it was a very nice talk, very illustrative. Just one question that probably you have already covered is related to, for example, the basics of the analysis for some Muslim families who have fasting periods and the effect that it could have, for example, in children. There have been some studies already that analyze, for example, educational outcomes, some other issues, but could be probably help us good comparisons within some communities. In fact, there have been analysis of siblings when they have been in or out of the Ramadan months. I would like to know if you have any other more thoughts on this idea.
So my understanding is that pregnant women are not required to fast during Ramadan, but a lot choose to do so anyway for religious reasons. So this may be a case where more public information about dangers of fasting during pregnancy might cause people to change their behavior, without having to violate their religion or anything like that. That would be it's one thing to do the research and it's another thing to get it out there to the people who need it. And I would say that research on fasting during Ramadan, it would be really great if the Muslim community knew about that and didn't feel that it was an attack on them, but just that this is how it is, and so we should make accommodation for pregnant women.
Other questions? Yes, over there, please.
Thanks. I was glad to see you mentioned adolescent health towards the end, because I've noticed, this famous Heckman curve is very, very famous and important, and it's, policymakers are a bit daft. They see this curve and they think that you should put all your money into the early years and you should never spend any money on anyone over the age of 10. And that, I think, has caused a lot of collapse, certainly in my country, in the UK. They've over-invested in Sure Start stuff and under-invested in child and mental adolescent services. So I don't know, are we going to see a Currie curve which remedies that? The serious question is, how do you get sensible information out to policymakers so they don't over-interpret stuff?
Right. That's always the issue. I guess personally I've found that the kind of things that get picked up by policymakers or in the media are not always the ones that you would have chosen, that you would like people to focus on. But I do think it's important, even if it's true, which I'm not totally convinced, that the effect sizes are generally larger in early childhood than in adolescence, that doesn't mean that it's easy to get those effect sizes or that that's the most cost-effective intervention. You have to know a lot more about the interventions and how much they cost and how easy they are to roll out and whether they can be targeted and all these kinds of things for you to be able to say. So I think we may see maybe not a Currie curve, but at least a reassessment of the importance of dealing with adolescents and finding interventions that are effective for them. We do know of some that are effective, and so building on that research base seems really important.
Great. Maybe one last question. Yes, all the way in the back.
Hello. Hi. Thanks you very much, Janet, for the presentation. I was wondering, so from an ignorant point of view, so the mental diseases or mental disorders, do we have a sense whether it's there's some variation with the socioeconomic status? Meaning, do we get richer kids who are more likely to get these issues? And if so, the question is not so much whether we should give them drugs, but like, where did we miss the path? Being like, we get richer, but somehow we are incorporating some behaviors that are making this kid have more mental disorders, right? So maybe we have to back up and see, it's more a matter of how we live more than diagnosing, prescribing drugs for the kids. I don't know if you have a sense of that.
Yeah, as I said, there are a lot of measurement errors in diagnosing mental health, particularly since there's so much stigma. One of the things that we noticed dealing with claims data was that it's not uncommon to have a claim where the child was prescribed a mental health drug, but we don't see any diagnostic category in the claim record. So the doctor has avoided putting down that the child has a mental disorder, even though they're actually treating them for a mental disorder. So those kind of things make measurement difficult. But I think the data that I've looked at do suggest that mental disorders follow kind of the similar pattern to physical disorders, which is that you're more likely to have them if you're poor. You know, you're more likely to be subject to stresses and strains of various sorts that might lead to mental disorders or exacerbate them. And so I don't think there's any reason to think that mental disorders behave differently with respect to socioeconomic status than other types of disorders.
Thank you so much. Thank you once again for an amazing talk, and really great having you. I would now like to invite Winnie James to come up here. Please come up, yes. Who wants to go first? James or Bruce? James, okay. Just go over to the microphone.
Where's the up and down button? Have you got the thing? Okay, thank you. So, the student prize. The iHEA Student Prize is to recognise excellence by students in the field of health economics. This is the 20th year the prize has been awarded, and from 2017 there's been a standing student prize committee to award this prize annually to the master's or doctoral student paper judged as best in the award year. Each year the committee considers a short list of submitted papers, and each year we receive between 40 and 50 submissions, and we award 3 prizes. Now, it wouldn't be possible to award these prizes without the committee. I'm not going to go through all of them. Some of you are here, but you all do sterling work, and really, it wouldn't be possible to have this award and do it every year without all of your work, which is, of course, on a volunteer basis. So thank you to all of you. Okay, so the prizes. There's going to be 2 lots of prizes because, of course, it's an annual award and iHEA isn't an annual conference, so bear with us. So we're going to get the prize givers, the prize receivers up for both years, one year at a time, award the prizes, and then it's the Early Career Researcher Award. Okay, so could the prize winners come up from 2018 first, please? So, first prize goes to Mujahid Shayak and Tobias Muller for Your Retirement and My Health Behaviour. Evidence on Retirement, Externalities from a Fuzzy Registration, Discontinuity Design. Okay. Thank you. Second prize goes to Ana Maria Costa Ramon and Ana Rodriguez Gonzalez for their paper, It's About Time, Caesarean Sections and Neonatal Health. Third is joint prize. It's Kitoi Roquebert and Marianne Tenand for Pay Less, Consume More, the price elasticity of home care for the disabled elderly in France, and Adrian Rubli for low-cost, limited-service private healthcare providers, evidence from Mexico. Thank you. Could the 2019 award winners come up, please? Okay, so first prize goes to Monica Aswani for her paper, Differential Impact of Hospital and Community Factors on Medicare Readmission Penalties. Second prize, now Barton isn't here, so Oscar's style, we're going to take it and make sure he gets it. So Barton will urge the effective weight on mental health, new evidence using genetic IVs. So you can applaud because you will be watching. Okay, and third prize goes to Panka Benzik, Stress on the Sidewalk, the mental health costs of close proximity crime. So thank you to all our wonderful winners who presented this afternoon, and the live stream is available for you all to watch who weren't there. The final thing for me to say is the 2020 prize submission opens in October, and you will all be informed about this, and the deadline is January. And as one of our wonderful winners said this afternoon, if you're worried about whether you should submit or not, there's only one way to win the prize, and that's to submit. Okay? So please do so. So thank you very much, and over to James.
Okay, thank you very much, Bruce. So on Saturday, the very first Early Career Researcher Pre-Congress session took place. How do you afford it? Okay. So the aim of this session was to provide a forum for early career researchers to receive detailed feedback on their work. We received 46 abstracts for this session. We selected 12 papers to be presented on Saturday afternoon. But these papers weren't, however, presented by the ECRs themselves. They were presented by senior health economists who all acted as discussants. In every session, without exception, the ECRs received detailed, constructive feedback that I think will improve their work from both the discussants and also the wider audience. So thank you to everybody who contributed to the supportive atmosphere in these sessions, in particular to the discussants who I've listed on this slide here. And thanks also to Di McIntyre and to Nicole Cork for their support with planning this session over the past year. Okay, we've also received great support from Wiley, who are the publishers of Health Economics, who have provided a prize for the paper that was judged to have the greatest potential to contribute to the health economics literature. So this prize comprises potential fast-track publication in health economics, books to the value of $150 from the Wiley catalogue, and a one-year online subscription to Health Economics. So I think a prize worth winning. A prize committee, who I've also listed on this slide, carefully considered the merits of all 12 papers, and I'm pleased to announce that the Best Paper Prize has been awarded to Vera Zabradina. So hopefully Vera is here. Please congratulate Vera.